We are in the Midwest. Good afternoon. Thank you for joining us. We'll give it just a couple more seconds for folks to come in, join us. And while you're doing that, there will be a Q&A box. We won't answer in real time, but for the really, really good questions, only the good questions, we will get back to you guys after the fact. But so make sure you put a good one in there, um, and then we can post them later. Give it a couple more seconds. All right, let's go. So thank you for joining us. This is the last in our series. We're going to wrap it up, and we're going to wrap it up with Mr. Drew. The man just goes by one name. You don't even have to say both names. He goes by one name, and you'll hear why in a second. Thank you for joining me, Drew. This is, I think, our third time being able to do something together. One webinar, one video, and then now another webinar. But I don't know how you could miss Drew. He is everywhere. He's on everybody's plane. He's speaking everywhere. But let me tell you quickly why I want to talk to Drew and why we want to hear what Drew has to say. Um, 20 years in security leadership roles, which includes higher ed and healthcare. That's cool. But the icing on the cake is being in over 200 healthcare facilities. So quite literally been there and done that and at least seen it. So he's a great person to talk to try to, get little bits of data from for you after this, of course, and we'll let you know where you can catch up with Drew. But this is why he was absolutely on my list of people to try to talk to for what we're going to wrap up with today, Drew. We're going to wrap up with um, cost savings. Cost savings in this physical access control space, specifically related to healthcare. I know you see and do a little bit of everything, but I'm calling on your healthcare experience. We kicked it off with Loris. We had Paul in there. We had Bill. We are wrapping it up with you, coming back to cost savings. We talked about risks, integration, automation. I'm going to specifically try to ping you around dollar amounts and what does that look like in healthcare.
No, and I look forward to the conversation. I think it'll be great. And I think it is an important topic, Clete.
Absolutely. Nothing gets done without, presenting to the board and talking about how much it costs. Um, and let me start with something shocking, Drew, and then you tell me some different things that you hear in that vein. But I confirm this number just because it's a crazy time, it's a crazy amount to me. But I confirmed it recently. A hospital facility they went through a multi-hospital um, unification of their access control. And again, we never say names of who does what and the technology, et cetera. Um, they went through a multi-hospital access control unification. It was 5 years, $10 million. Am I crazy? Or do you hear this often? Like what's your take on that?
That sounds a little bit short and a little bit cheap, actually. It's the
No.
costs can really skyrocket very quickly, especially as you well know, you've worked in the healthcare space for years, that healthcare is currently undergoing mergers and acquisitions left and right, formerly independent organizations coming
Uh-huh.
together, trying to pull themselves together into one system and making everything work together. And really, I think from a per door cost, what I see is anywhere from 1,000 to well over $5,000 per door to change over and integrate access control systems, which that of course is dependent on a large number of factors. It's whether the systems that are in place already have
Uh-huh.
proprietary hardware, whether they work together, whether you're in a historical building where any hardware changes have to be vetted by outside agencies.
Wow.
That's something not as much in our healthcare practice, but some in our healthcare practice. But we see that a lot in our higher ed practice, where we're working in a lot of historically significant properties, where just changing one piece of hardware on a door can be can take months to get approval for. So
Wow.
I think absolutely there. 5 years and $10 million is not out of line whatsoever with what I've seen for a
That's the
system to
highest
bring
I've
together.
ever heard, Drew. That's the highest and probably the longest. Maybe I wasn't privy to some data, didn't get that, but that's the highest and the longest. And then I'm glad you mentioned per door cost. I was going to ask you about that because um, pre-COVID, people were telling me, Clete, they're running like 2 to 3 grand per door. And then after COVID, they told me it never changed. It never went back down. And they're telling me, oh, Clete, it's like 4 to 5 grand per door. So it's cool to hear
Yep.
you say the same number. I've seen as high as 5 grand per door.
Usually, with no extenuating circumstances, I use 2,500 per door as a budgetary number for my clients. That's typically, if it's not New York City super talls or it's not in a really high cost of living area where costs are higher,
Yep.
I would say use an average of about 2,500 per door as
So
an
since you
assumption.
say average, that's what so doing the math on, and this was just based on Google, but when I said average number of doors in a hospital that might be secure, coupled with when they were initially telling me 2,500 a door, there was a point when I used to tell people, napkin math says about 500,000, 750,000 per hospital if you got to do a forklift. You've done this exercise now. What's your number? What's your number now that you would tell people if they're asking you to come through and gauge what it looks like for them?
I mean, it does. It's hard to put a solid number out there without knowing where doors are, what the system you're moving from is, all of those pieces.
Right.
I can tell you there's one large academic medical center that we are currently engaged with that I did an assessment for about 2 years ago and identified that, hey, your access control system is at end of life. It's a proprietary system. You need to move forward with something else. But we're working with them through that process. And for a large academic medical center in a medium cost of living city, they're spending, it's a little bit, I think it's between 10 and 11 million to the vendor to do the
Golly.
actual hardware, programming, all of that. They're spending close to $1 million for a external firm to project manage the process for them. Plus, they're spending thousands, if not tens of thousands, of internal hours of their staff to
Mm-hmm.
manage it. So I'm
The
sure
project
it,
managers and all
they're
that. Yep.
trying to accomplish this over 2.5 years. Whether they'll hit that number or not, we'll see. But it's probably going to be in total between internal resources and capital expense and operating expenses, probably going to be close to a $15 million project.
So we know. So that example, the one I gave, so we know it's crazy expensive. We know it's going to take long. You said they're going to try to do one in a couple years. I told you the one I knew about was 5 years, and I'm sure there's all kinds of things in between and on the outskirts. We know it's expensive. We know it takes long. Do hospitals have to? Like when they gobble up, like to your point, they gobble up somebody independent across town, Saint someone, they gobble them up and they're now part of it. Um, what's the pain point from your perspective? Because I think we heard it elsewhere. What's the pain point from your perspective in just keeping all these different systems? Like, why would they even try to unify?
And I think at risk of going on a long story because I
Yeah, we
I
got to be
talk through
quick.
telling stories. I think I can illustrate that pretty well through a non-healthcare example. Frankly, I think the last company I worked for before I started consulting, there was a financial services firm that made an acquisition of 68 career college campuses located throughout the United States. So we've got 68 geographically diverse campuses. Most of
Mhm.
them were commuter campuses, so not huge, but some were multi building residential campuses located. I think we're in 18 states. So it's
Mhm.
68 campuses, five support operations and headquarters offices. In those buildings, when I took over, I had 37 different electronic access control systems and 72 video management systems and I think 70 some different alarm systems that were
Mhm.
all diverse. We're all going different places. We're all being managed by people locally on the ground. The expense of that and the resources we were putting to working through that were enormous. We actually, and that I think we're talking similar costs here, that I got a project approved to move all of that to a singular system. And that was just under a $12 million project over a little over 2 years that I took to do it. But with that, we had less than a 3 year ROI on it with the savings we got out of it. We
That's the
had,
key.
we sat down and did the math to take to our board of directors because that was a huge expense to bring
Yeah.
forward. But we were saving 1.2 million a year in labor of the people who are manually programming all of those different systems and all those different places. We ended up moving to a single system. We saved, I think it was 750,000 in licensing costs. We ended up saving over 200,000 in alarm monitoring costs because we were able to integrate that into the access control system.
Hmm.
We actually, as I said, we had 68 campuses. We had 37 access control systems. We had campuses that, because of the labor requirements and the management requirements of an access control system, felt they couldn't do it on their own. So they were using security staff for access control. I had
Hmm.
one campus in an area of Atlanta, Georgia, where they had decided that they needed a security officer at every door because they didn't have an electronic access control system. And then because they needed to manage access to the campus. Just there, I was able to save 1.9 million a year by saying, "Hey, guess what? We're going to move to an electronic access control system and we'll put it in and we'll manage it for you from headquarters because you don't know how to manage it and you don't want to take that on, but we can save you close to 2 million a year." So with all those savings, and there were some other ancillary savings in there too, we ended up saving the organization about 4.2, 4.3 million a year. So paid back our capital expense in less than 3 years.
So outside of that example of where you literally did not even have access control, you were doing it with a guy or girl, you were doing it with
Yep.
a uniform officer. Outside of that example, um, that's exactly the sweet spot that I see for healthcare. Meaning, you already said the pain, and others have said that pain. It's all these different systems that I have here. There's this process, there's that is how much it takes this guy to do it, and you said that there's a cost savings there right away. Um, but where we are now with technology, and I believe it was Bill commented on it, like, he feels like it would be more of an adoption in the future. Where we are now, that cost savings can come without unification.
Agreed.
That's the part that we're trying to get others to see, and that's the part that, when you're out and about talking, but you experienced all those pains. It was this incredible outlay of costs to get it done, but then there was the ROI. Both of those things are there, even when we're talking about a PIAM system. Those are both there. You get the cost savings of all that manpower after the fact, which I want to touch on next. I want to touch on manpower. But then you didn't have to do this initial outlay of millions and millions. You didn't have to do that. But like you said, in some cases you do. Some things are end of life. Obviously, you have to be able to service them, and then you have some where they weren't there at all.
And I
But
think the other piece that we have to look at before we get to manpower is most healthcare organizations that are consolidating and are acquiring other systems and are merging are geographically located in similar areas. It's not
Mhm.
a healthcare system in Wisconsin buying a hospital system in Southern California or
Mhm.
in upstate New York.
Yeah, they do a
It's
region.
typically a large system buying smaller systems that feed into it from a tertiary perspective. So they're
Mhm.
buying the critical access hospitals, the ambulatory sites, and where we saw in one of my prior employers that was going through that, where we saw a need for cost savings was in how people are getting access to multiple hospitals. So if you have a single hospital with a singular electronic access control system, great. Your security department, your HR department can issue Dr. Smith a badge
On
that
one
works for
bag.
every door in that hospital.
Right. Right.
Great. But when you move to multiple organizations and multiple organizations that have put in disparate access control systems,
Mhm.
you end up with the need for staff who are moving between those, which is where we get the efficiencies to
Hmm.
have multiple cards, access to multiple facilities. I was actually just in a large academic medical center that has acquired a number of other smaller practices over the last several years. This was about a month and a half ago, and talking to their chief medical officer and trying to feel out this pain point. And I asked him, so you, as the chief medical officer for this new enterprise, are going to each of these locations. How do you get in? How do you get through the doors? Can you do that all on one badge? He
No.
pulled his badge off his shirt and he had 9 badges stacked together.
9?
9. He had 9 badges that he needed to get access to all the places within that organization that he needed to go.
Not
So
not
now,
uncommon.
not only is each one of those cards, depending on what technology it is, costing somewhere between a buck something and $10 if it's a smart card,
Hmm.
but and multiply that by how many thousand employees you have that are moving between. But each one of those has to be individually programmed, individually managed, and that can be a huge cost in
Hmm.
staff resources as well to move us into the staffing conversation.
And when it comes to staffing, I hate to sound trite, but that whole thing of do more with less. So the same thing that applies to, you spent all this money to acquire these separate hospitals, et cetera. Do more with less. What can we do with what they already have? We can do some things with that. We don't have to unify. But then that same thing comes down to uh, the people that are there. We have 10 uniform people that are there. They are managing safety and security. What I have heard of, and what I want you to weigh in on is, I have heard people say, Cleet, I'd like to get them out of the basement, issuing lost badges, filling out forms. I'd like to get them out of there doing, lost and deactivating badges. I'd like to get them actually um, performing guard duties in the ED, things, walking the perimeter, things like that. That's what they're there for. That's what they're there for. Um, how often do you get a chance to get out and see? And are you seeing that this is a badging team, which it doesn't need to be a badging team, or you're seeing uniformed officers that are there that are actually not on the grounds the way they should be?
It depends on the organization and kind of what they have historically done, and frankly, the size of the organization a little bit.
Hmm. Hmm.
And then how efficient they are at badging. I've seen some organizations where human resources is managing almost the entirety of their badging and clearance issuance process. I've seen smaller organizations where,
Hmm.
yeah, it's absolutely, it's a security officer getting called off the floor to go generate a badge, print it out, bring it to the person. I've also seen hospital systems with teams as large as 20 people or a few more working purely to print and provision access control
Managed
cards.
badges. Yep.
Yep, just to
Yep.
manage badges. And yes, there are a lot of things we can do to automate that, but I still
Yeah.
see probably at least half the facilities I go into that that's a manual process. Access is
Hmm.
being requested even either through a facilities management system or via email and going to an access control team who are then typing it into the system, who may get a list from human resources of here are the new employees, and they have to go into their access control system and create a record for each one of those employees,
Hmm.
which is hugely time consuming when we can automate that fairly easily with most systems.
That
When you
part.
have disparate systems, then you have a little bit more of a challenge, but there are ways to do it.
And
And the
that's where
savings can be
PIM, that
immense.
challenge right there is where PIAM comes in, because like you said, when you have disparate systems, it is harder to do it. So that is where PIM plays in there. Um, and then you said also, when you talked about the inbox, this is more on the security side, which we talked about, I think maybe with Paul. But the other thing, when you talk about managing um, the using the people to manage the inbox, the people are not 24/7 the way a hospital is. As Kyle says, or no, my sales leader says, software never sleeps. So unless you have seen different, I have not seen yet a healthcare 24/7 badging operation. I think you mentioned like how they are running over the inbox. I've seen that inbox, the inbox method, but that's still a Monday through Friday thing.
Yes, it is. And that is typically where I see it rolling over to those security officers on the floor who may be needing to deal with something else at the time, but are getting pulled in because Dr. Smith's badge isn't working today for some reason or forgot the badge. And now we have to go through that process to get that up and running. Or badge doesn't work for that particular hospital because it wasn't in the system that hospital uses
Mhm.
versus the large regional medical center that they're affiliated with.
And so we will hit some key topics here as we wrap it up. Key topics. We're talking about um, that initial outlay, and I'll have to now go back and watch this and update my figures because now you're telling me I'm low. But that initial outlay, that per hospital cost, and then you said it before I even got a chance to say it. I have done the math with hospitals where there's an ROI on all the work those guys and girls are doing in the background. Thankfully, you said it first, so I didn't have to bring that up. You said it first, and because you had to do it for your other facility. You had to show that ROI. And that's what this entire session was about. So, parting words from you as we wrap up the cost savings that come around hospital, that can come around hospital physical access control. Any parting thoughts from you?
Yeah, I think one of them, and I don't know if it's a parting thought, but one thing to look at, and I actually had to undergo this exercise for one of my clients several years ago. They had a relatively broken physical access provisioning system. Yes, they could get badges to people, but getting people the right access to get where they needed to go was a severe challenge for them.
It was
And
manual.
what?
It was manual.
It was manual, it was a challenge, and frankly, they weren't doing it well. Even though they had a large team of people dedicated to it, it wasn't occurring well. And
Hmm.
it came out during our interviews because when we're on site with the system, we talk to people. That's where we get our information.
Hmm.
We talk to the staff and try to understand what their pain points are. And in this hospital, I talked to one nurse who had worked in their emergency department. She was a nurse manager of their emergency department, had worked in their emergency department for 12 years, but didn't have access to get into the emergency department.
After 12 years?
She said, I requested it probably 20 different times. I worked with public safety a number of different times, but it's just never worked. So now I just come in a few minutes early and wait for somebody to open the door and I follow in behind them. And so that conversation and several similar conversations we had with others caused us to go in and look, all right, let's pull a report of all your rejected badge swipes for, I think we did a 6-month period. And it was an overwhelming number. And we parsed that
Mm.
down a little bit and looked at, okay, which of these look like they should be legitimate? And we're able to extrapolate out of that okay, if a staff member is trying to get into a door that they should have access to and they don't have access to it, how long does it take them then to go find somebody and get into that door? And it, on average, I think we assumed it was about a minute and a half, which isn't a huge amount of time, but it's still, if you're doing that multiple times per day and
For years.
by the number of employees you have, by a year, we were able to tell that organization that if you fix this problem, you'll save, I think it was right around $4.6 million in labor cost annually, which was huge.
Thankfully,
It's
I've never
insane.
been challenged on those ROI numbers, but we
Yeah.
come up with them the same way. There's a time associated. I think you said Dr. Smith, using your
Yep.
example. There's a time associated with Dr. Smith waiting on entry. There's a time associated with Officer Cleat having to go and give a lost badge because there was nothing that the person could do themselves. There's absolutely an ROI to be had when it comes to some things in healthcare security. Some things just have to be what they have to be, but I absolutely try to preach that same message, Drew, that there is absolutely cost savings that comes with some of the things that you can do in healthcare security, and physical access control is one of them.
Yep. No, absolutely. And I think from a parting parting statement standpoint, I think the other thing, while we're talking costs, I think, yes, you can pretty easily define some of those hard costs. The part that you can't define with problems with access control is, all right, Dr. Smith not being able to get through that door, the security officer not being able to get through that door. What is the
Mhm.
cost of that risk? Because the doctor probably doesn't just want to get into the lounge. He may be going to help a patient. There may be an emergent situation that minute and a half delay is going to cause death or serious harm to someone. So how do we help manage
Quantify.
that?
Yeah,
Yeah.
yeah, that's a great point. There's a lot of things that are not quantifiable. I've been asked,
Yeah.
especially when it came to visitor management. Well, Cleet, how do we quantify some of these risks? And I've asked several people, and they talk about fines, et cetera. But that's a great point. That's a great point. And thank you for joining us, Drew. This was we're gonna have to do something similar because I mean I see we could do this for a long time. We'll have to do something else, and then we're gonna leave information for people to be able to get in touch with Drew. Clearly, he's been there and done that, and, and knows what the heck he's talking about. Thank you again for sharing your time with us, Drew, and your insight. Thank you very much.
Well, thanks for having me. It's always a good conversation, Clete.
All right, sir.